We are live now, ma'am. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, TNFOG with Madhya Pradesh Societies. So it's my privilege to introduce the embassy of today's webinar, Dr. Madhumita Arun Karthik ma'am. Ma'am is the consultant obstetrician from Salem and National Coordinator of Midlife Management Committee, FOXY. I welcome you, ma'am.
Thank you so much, Sahiti, for the kind introduction. Now we'll start with the prayer and lamp lighting.
Hello. Good evening.
Sahiti, I think you can mute and kindly try to make a
Good evening, everyone. I'm happy to welcome one and all to this webinar along with Tamil Nadu Federation Societies with Madhya Pradesh Societies. And I'm really extremely grateful to all the presidents and secretaries of all the societies who are actively involved in this program. And this webinar is brought to us by the organizer, Professor Dr. Sampath Kumari ma'am. It's my honor to introduce ma'am, who's a professor and HOD at Sri Muthukumaran Medical College and Research Center at Chennai. She is a past vice president of FOXY, the Senate member of Tamil Nadu Dr. MGR Medical University, national corresponding editor of JOGI, founder secretary of Tamil Nadu Federation of Obstetrics and Gynecology, and immediate past president of Obstetricians and Gynecology Society of South India, and a retired deputy director of IOG Chennai. And she was a past chairperson of FOXY Adolescent Health Committee, and she received the first ICOG Distinguished General Council Member Award. And she's also the chairperson of Women's Wing, IMA Chennai South. And she received the IMA National President's Award and IMA TN State Branch Award in 2021. Over to you for the welcome address, ma'am.
Yes, thank you, Dr. Madhumita. I welcome you all for this webinar on preeclampsia and other complications. See, this is the webinar with Tamil Nadu Federations with Madhya Pradesh Societies, Gwalior, Bhopal, Katni, Rewa, Ratlam, and we have Japalpur, Ujjain, Saha, and all president and secretaries of all Bhopal societies have joined, and we have Dr. Anjali Madam. She is that all Madhya Pradesh Society president, and our own TNFOG president, Dr. Vidya Prabhakar. I welcome you all for this webinar. I think it will be useful for all of you, and I welcome the delegates also. Now we will go with the chief guest and the guest of honor wishes. Can we have the CV of Anjali Madam has joined?
Ma'am said that she has informed you she's in some emergency. If possible, in the middle, she'll join, ma'am.
Okay, then we will go with Dr. Vidya Prabhakar. Dr. Vidya Prabhakar is our own TNFOG president. She was our past Salem Society president, and Madam is involved in many social activities, and she is doing that HPV vaccination program. She was assistant professor KMC Manipal and ART training, and she had training from Singapore, senior IVF
you, ma'am.
consultant, and recipient of many awards and from Foxy. Vidya Madam, welcome, Madam.
Thank you, ma'am. Thank you so much.
Session.
First of all, I'm happy to be here, part of this webinar on preeclampsia, because as you know very well, Sampath ma'am, the topic that is closest to my heart is reducing the maternal mortality. And recently also we found out that one of the WHO people had given out an information. There are still so many deaths happening in India, and most of them are preventable. Other causes and all contribute very less. The main three causes happen to be hemorrhagic and preeclampsia, eclampsia related, and sepsis. So, however, however much we talk about it, as many webinars we hold, as many seminars we hold, we still have something to learn. And I think even now, many of the places people don't screen so much for preeclampsia. Actually, I think it should have become a routine by now, but I think by increasing the awareness, we can do that. I'm sure all of you will be doing that today. And I'm very happy to be part of this webinar with all the Madhya Pradesh societies. So many societies have joined, and I'm very happy to be here. I would like to hear out what is going on in the program. All the very best, ma'am. And I would also like to wish Sampath ma'am all the very best for the upcoming elections. And I would request all the MP societies to vote for her too. So make sure that you all vote for her and make her a big success story. Thank you very much. Ma'am, you are muted.
Ma'am, Sampath ma'am, you're muted, ma'am.
Mhm.
Sampath ma'am? Ma'am, Sampath ma'am, you're muted, ma'am. Sampath ma'am?
Ma'am, please unmute.
Yes.
Yes. Now we will go with the scientific session, I think. Now 1 minute. Something. Madhumita?
Yes,
you
ma'am.
introduce Dr. Jyoti, madam. Here
moving on to the first session, we have a wonderful talk on prediction and prevention of preeclampsia, and for that we have our chairperson, Dr. Jyoti Chauhan ma'am, who is the president of Sagar branch of Foxy, and she's the ex-regional director of Sagar division. Ma'am did her MS from the same college and won the first position in the university. She was the first lady civil surgeon of the district hospital at Sagar. She has received various awards like the Nari Shakti Saman Award, Incredible Women Award 2020, Excellence Award in 2022 from the Health Minister, and she's the recipient of DK Tank Trophy and Durusha Award for Adolescent Activities and Sadhana Desai Award for Population Control Activities. We're very happy to have you today with us, ma'am. Over to you, Jyoti, ma'am.
Dr. Madhumita. Thank you, Dr. Madhumita. It's a pleasure to be here on this webinar on such an important topic, which is one of the causes of maternal mortality, one of the leading causes, I should say. So that's really amazing that Madam Sampath has arranged this webinar on this very topic. She came to Sagar and she spoke very well on this topic. We wish her all the best, and we wish all the MP societies, I think, would definitely vote for her, and she would be a shining star at the national level. That's what my best wishes are for her.
Thank you, Dr. Jyoti. We have Dr. Archana, Dr. Raki, Dr. Monisha, Dr. Nasia, Dr. Rekha Singhal, Dr. Shweta, Dr. Swati Jain. So all of us are there. Dr. Jyoti, you can introduce Dr. Madhuri Chandra.
Yeah, can I have a biodata here?
Right, but I don't really think you need to do my biodata.
Oh, Madhuri, you really need to be introduced properly.
Yes.
She is one of the leading gynecologists of Madhya Pradesh and a very simple, down-to-the-earth person. And she's an excellent teacher. That's what I can say from my experience. I worked with her, and I've also heard her speak in so many webinars and conferences. And the official data to dikh nahi raha hai.
Okay, thank you, Jyoti. I did.
Jyoti, she was HIV committee chairperson, and she released a book. And she has done many works in the Foxy. And now she will be talking about prediction and prevention of preeclampsia.
Thank you so
Yeah,
much,
over
Jyoti,
to
for
you, Dr.
introduction. And
Madhuri.
thank you, Dr. Sampath, at the very onset for allowing me to speak a few words on prediction and prevention of preeclampsia. I'm trying to share my slides.
Yes, ma'am.
Yes. Mhm.
Sahiti, is ma'am the co-host? Just make ma'am the co-host, no?
Okay, ma'am.
Yeah. Yeah, ma'am is made the. Yes, ma'am. You're able to see your screen. Just make it full screen, ma'am.
I'm just doing it.
Yes, ma'am.
Okay. Now,
Yes,
okay.
ma'am. Yes, ma'am. Yes,
So,
ma'am.
yeah, we are going to quickly go through the prediction and prevention of preeclampsia. Now, why are we talking of preeclampsia today? If you see the, let me put this up, okay? If you see this particular slide, okay, and you see the studies, you will find that MMR now in India is 97 per 1 lakh. But the leading cause are the preventable ones, okay, like preeclampsia, accounting for about 12.9% of all deaths, abortions, obstructed labor. They still dominate in the maternal deaths, okay? And that is why we are going to talk on preeclampsia. The preeclampsia is one of the hypertensive disorders of pregnancy with an incidence of about 2 to 10% in all pregnancies. They could be classified as gestational hypertension, preeclampsia, eclampsia, superimposed preeclampsia, and chronic hypertension. We'll not go into the details of this, and nor will we go into the details of etiopathogenesis, other than emphasizing that it is a failure of the second wave of trophoblastic invasion of the spiral arteries, which results in vasospasm, endothelial activation and damage, and intravascular coagulation with fibrin deposition. And this results in problems in the end organs, that is the kidney, the brain, the liver, and the blood. And that is responsible for all the symptoms and signs of preeclampsia. Now, mild and moderate, severe preeclampsia, there was a classification before, but now we no longer want to classify them as mild and severe for the simple reason that this could be misleading, and apparent mild degree, disease may progress rapidly to severe forms. Okay. And just emphasizing what is the severe preeclampsia: a blood pressure more than 160, 110, proteinuria more than 2 grams, oliguria less than 400 ml of urine in 24 hours, increased serum creatinine, platelets less than 1 lakh per cubic mm, evidence of microangiopathic hemolysis, elevated liver function, persistent headache, visual disturbances, persistent epigastric pain. Why all these are important is that they are also signs of another old definition, that is eminent eclampsia. And it is eclampsia that we want to prevent, and that is responsible for a lot of maternal morbidity and maternal mortality. Now, what is the prediction that is available to us? There are many screening methods, but none are having a good sensitivity or specificity. Okay. You have some which can predict early preeclampsia, and you can use them in the first and second trimester. However, late preeclampsia is more difficult to pinpoint. Primary prevention means the identification of the risk factors, while secondary prevention would involve physical activity, diet modification, use of aspirin, calcium, antioxidants like vitamin C, E, and lycopene. We'll go into detail of all this. Now, what is the prediction? Prediction would depend upon maternal risk factors, certain biophysical factors like the mean arterial pressure, uterine artery Doppler studies. Then biochemical markers could be angiogenic factors like soluble FMS-like triosin, that is known as SFLT1, placental growth factors, also known as PLGF, and soluble endoglin. Okay. Early detection means that you're going to invert the pyramid of antenatal care. And early prevention would mean administration of aspirin, preferably before the second wave of trophoblastic invasion is to occur, that is as early as about 11 to 12 weeks. What are the maternal risk factors that we are talking about? It could be personal risk, very young age, high age, ethnicity, all this you all know. Parity, smoking. Then the conception method, IVF conceptions are more likely to become preeclampsias. Metabolic risk, a high BMI, history of diabetes. Medical risk, like increase in the mean arterial pressure, pre-existing hypertension, pre-existing renal disease, inherited thrombophilias, and SLE. Then there could be certain obstetric factors which develop in this pregnancy. It could be multiple pregnancy, a history of previous preeclampsia, molar pregnancy, triploidy, hydrops fetalis, and an interpregnancy interval of more than 10 years. We like to keep an interpregnancy interval of more than 2 to 5 years, but more than 10 years is more likely to result in preeclampsia. And placental risk, like uterine artery Doppler and maternal high-risk biomarkers, we'll talk about in great detail. These are the risk ratios of the preconceptional risk factors of preeclampsia. We'll not go into detail of them. That's just a table that I'm showing you. And these are the pregnancy-related risk factors for preeclampsia. Against the risk ratio is shown over here. Then you have the USPSTF task force, which means says that screening and prediction should depend upon identification of the maternal risk factors, and screening test is the mean arterial pressure that they advise. Then you have our own gestosis risk code. That means everybody is coming up with a high risk code. You have the US one, now you have the Indian one, which is gestosis high risk code. Again, taking in the various factors that I've just described, the maternal history, the pregnancy, current pregnancy, the medical history, the obstetric history, her physique, past medical histories, etc., etc. And all of them are scored. The higher the score, the more the risk. Then you also have 3 other guidelines, that is the ACOG, NICE, and again the US Transpose. And they, along with FIGO, which also give you how to identify or how to predict the ones that are going to develop preeclampsia. But the most reasonable one that I have come to is this one, which is also advised by the Fetal Medicine Society. And what are the ones that they say? That screening for preeclampsia should be at 11 to 13 weeks, as early as 11 to 13 weeks. You should look for the maternal risk factors, which we've just described in details. You should look for biophysical markers, such as the mean arterial pressure and the uterine artery Doppler, and biochemical markers in the form of PAPP-A and placental growth factor. This would help you to identify early preeclampsia to 90%. Okay. However, you will still not be able to pick up the late preeclampsia so much. That is only with a 60% pickup rate. So this is what Fetal Medicine Foundation says. The total is given over here. Okay. What are the risk factors? What has to be taken into consideration? We are going more and more for early, not double marker, but penta marker or penta screening in order to also be able to pick up the preeclampsia. Mean arterial pressure, how to take it, we will not go into the details, but you calculate, and the normal range is between 65 to 110. If it is more than 110, especially in the first trimester, when it actually should have fallen, then the lady is at great risk of developing preeclampsia. Uterine artery Doppler, again, the scan should be done at 11 to 13 weeks, 6 days. And both the arteries should be seen, both the uterine artery and a mean arterial PI should be calculated. This is the way that you pick up the uterine artery Doppler. You see for the pulsality index. Okay. In the first trimester, it should be less than 2.5. In the second trimester, it should be less than 1.5. If you find it more than 1.5 with a persistent diastolic notch after 16 weeks, then the lady is at higher risk of early preeclampsia. These are showing the normal Doppler studies in the first trimester. If you see the uterine artery PI, it's about 1.7 in the right, and in the left, it is about 1.2. Again, in the second trimester, normal uterine artery blood flow with a PI of 1.1 in right and a 1 in left. At 26 to 27 weeks, there has been a change. The PI in the left uterine artery is about 3.9. So prevention of this is prediction going by the mean arterial pressure, the maternal risk factors, the uterine artery Doppler, and certain biochemical tests such as the PLGF and the PAPPA. Okay. Now, how to prevent? If you find that the person is at increased risk of preeclampsia, then you find out what is causing it. Is it a personal risk? Is it a placental risk? For these, the advice would be to start her on low-dose aspirin. Is there a cardiovascular risk? Again, you go for early blood pressure management and low-dose aspirin. If she's at a metabolic risk, identify what is the high-risk factor. Is she having GDM? Is the weight in a problem? You may think about use of metformin. If there is a high lipid profile or an altered lipid profile, the drug of choice would be a pravastatin. If she's a prothrombotic risk, again, you would like to give her low-dose aspirin and think of giving sufficient folic acid if she's got high homocysteine levels. This is how you would prevent HDP. And the study was by Paschat in ultrasound obstetrics and gynae. Okay, that's where I'm quoting from. These are the various other things that you've considered for preventing preeclampsia. Let us go over them one after the other. Well, evidence from review, and the review is by Rombold, does not support routine antioxidant supplementation during pregnancy to reduce the risk of preeclampsia. So antioxidants, no role. Antiplatelet agents like low-dose aspirin have moderate benefits when used for prevention of preeclampsia and its consequences. Further information is required to assess which women are more likely to benefit. So low-dose aspirin, definitely there are studies which tell you that it is effective in prevention, especially of early preeclampsia. And what is the dose that is advised by FIGO? 150 milligrams of low-dose aspirin daily at bedtime. You start at 11 to 14 weeks and continue up to 34 weeks for high-risk or high-risk women. Remember that even this low-dose aspirin does not help in prevention of term preeclampsia, that is after 34 weeks. What about calcium? There is a modest reduction. This is a Cochrane review. There's a modest reduction in preeclampsia, and the effect was greatest in women who are at high risk of hypertension and those with low baseline calcium intake, or like women in India who do not have enough dietary calcium intake. And what is the calcium supplementation that is advised? It is 1 gram of calcium daily from booking to delivery, because you want her to have the supplement as well as the dietary intake equal to about 1.5 grams to 2 grams of elemental calcium per day. So we'll supplement with about 1 gram. What about diet and exercise? What is their role in prevention? Exercise is recommended to prevent preeclampsia. For women at increased risk of preeclampsia who are overweight, dietary advice in the like reduced calorie and choosing foods with low glycemic index and exercise are recommended. So preeclampsia is a disease of science, and when symptoms occur, it is a little late. So what about this late preeclampsia that I'm talking about, and that is not likely to be picked up by your MAP or your other biophysical markers or your biochemical markers? Well, for late preeclampsia, that is preeclampsia occurring at 30 to 33 weeks, screening should be by a combination of uterine artery PI. Remember the patient that I showed you who developed in one left side of 27 weeks an increase in the uterine artery PI. Okay, they can help in identifying about 90% of the cases developing preeclampsia or within the subsequent 4 weeks, within the next 4 weeks. Measurement of placental growth factor or the FLT1 are highly accurate in identifying the target group. So screening for term PE at 30 to 33 weeks could be a combination of factors like placental growth factor and SFLT1 this would identify all cases who are at risk of developing preeclampsia within the next 4 weeks, with a false positive rate of about 5%. Management would depend on prenatal surveillance, hospitalization, interventional expectant management, glucose corticoids, delivery. I'll just quickly go through this. It's not really part of my topic because my topic was prediction and prevention. Bed rest should not be recommended routinely for hypertension in pregnancy, especially since more women prefer unrestricted activity if choices were given. Antihypertensives, now that is really life-saving, and you must start antihypertensives if you see 2 readings more than 140 by 90, 6 hours apart. Antihypertensive drugs are not associated with any change in risk of preeclampsia, fetal neonatal death, preterm birth, or having a small for gestational age baby, but they do help in decreasing the maternal morbidity and mortality, and half the risk of developing severe hypertension. Magnesium sulfate, yes. Magnesium sulfate, more than half the risk of eclampsia, reduces the risk of maternal death. It also, we know, though it is written over here, does not decrease the outcome of the baby in the short term. We know that it has a neuroprotective effect on the preterm baby. Now, should you intervene or should you do expectant management? Data is not sufficient to decide whether it is better to have a expectant care for women with early or severe preeclampsia. Lack of human and maternal resources to monitor the women extensively for a prolonged period may make expectant management difficult to implement. And we would like to do a interventionist management as soon as fetal maturity is documented. Steroids, yes, if the gestation is less than 34 weeks. And now increasingly you are having guidelines like the NICE guidelines, the AICOG guidelines. We even advocate that steroids should be given as late as 36 to 37 weeks also. They decrease the respiratory distress syndrome and improve the neonatal outcome. Advice is 2 doses of betamethasone, but we know in India we don't get the right salt of betamethasone. So advice is dexamethasone 8 milligrams every 8 hours for 3 doses. Maximum benefit would occur after 48 hours. There is no benefit of giving repeat weekly doses. Delivery is the cure for preeclampsia. Severe preeclampsia demands anticonvulsants and antihypertensives, followed by delivery. Route depends on fetal condition and favorability of cervix. Epidural or spinal block is safer than just GA for cesarean section. IV fluids should be restricted to less than 80 ml per hour. Aim to deliver severe preeclampsia within 24 hours of admission and eclampsia within 12 hours of a convulsion. Active management of the 3rd stage of labor with oxytocin should be done, or you can even do with carbotocin, that is now advised. So in a nutshell, what is the proposed screening and for prevention and prediction and prevention of preeclampsia? In the first trimester, this is the slide that we must all understand, that is 11 to 13 weeks, all pregnant women should be screened for maternal high-risk factors, for their mean arterial pressure, the ultrasound for uterine artery PI, the biomarkers such as placental growth factor for their risk evaluation of preterm preeclampsia. If they are at high risk, this is the time to start aspirin, low dose aspirin, and a dose of 150 milligrams. If they are low risk, you needn't give them any aspirin at this time. Then, when the woman reaches 2nd trimester, you must do a quadruple test risk assessment. All pregnant women, again, should be screened by their mean arterial pressure, the uterine artery PI, placental growth factor, maybe SFLT1, risk evaluation, again for preeclampsia. If she is high risk, you do high-level surveillance for preeclampsia, symptoms and signs between 24 to 35 weeks, and reassess at 35 to 37 weeks. If she's low risk, you put her in standard surveillance and reassess at 35 to, 35 to, my cursor seems to have disappeared. Okay. 1 second, I'm having some trouble with my slide. Okay, so let us come to this. What is the FIGO best practice advice then? Women with previous HDP are offered first trimester combined screening for assessment of their risk of preeclampsia. Women at high risk of developing recurrent HDP should be recommended for aspirin prophylaxis. Following a pregnancy complicated with HDP, what has happened? Postnatal women should be informed about the risk of recurrence in future pregnancy and advise dietary and exercise modifications to reduce the risk. Written information regarding risk of recurrence in future pregnancies and measures for reducing such risks should be provided to the postnatal women. So what is the pragmatic advice that I can give? Where resources are limited, first trimester screening for individualized assessment of the risk of recurrence is based on maternal factors, mean arterial pressure, if possible, early ultrasound for uterine artery Doppler, and the biochemical markers in the form of PAP-A and placental growth factor. So preeclampsia is like this, a long way to go. But if we want to decrease the maternal morbidity as well as mortality, because we've somehow conquered hemorrhage now. Hemorrhage is no longer among the first of the causes of maternal deaths. If we want to somehow conquer preeclampsia, we need to go into the depth of this. And the first advice would be early screening for risk of preeclampsia with maternal risk factors, ultrasound and biochemical factors as early as the 11th to 13th week. Thank you so much.
Thank you, Dr. Madhuri. You really made a very comprehensive presentation which covers each and every point of predicting and screening and actually being prepared for the worst. So if you're actually looking for the way you have mentioned each trimester wise, every according to the resources that they are there, everything you have explained so beautifully. It was really nice. Everything very concise and to the point.
Thank you, Jyoti. I think I went a little fast, but the time is a little limited. Okay.
No,
and
Madhuri,
preeclampsia is a very vast
very good.
topic.
Very vast topic you have covered within 20 minutes. Fantastic. Nice topic.
Thank you so much. Thank you so much.
I told Dr. Madhuri only 3 days, but 2 days back. She has prepared and presented. Thank you, Madhuri, for the last.
Welcome, Dr. Sampath, and all the best. All the best.
Thank you, Dr. Madhuri.
She's a
Dr.
teacher of
Jyoti, thank you
teachers.
so much.
Thank you, ma'am.
Yes.
Thank you so much,
Dr.
Jo.
Nidita, welcome.
Good evening, ma'am. Good evening, Madhuri, ma'am. Good evening, Sampath.
Good evening. Good evening.
Good evening, ma'am. Welcome, ma'am.
Yes.
Yes.
Yes, Madhumita.
Thank you so much, Madhuri ma'am and Jyoti ma'am, for such a wonderful session. Now moving on to the second session, which is a panel discussion. We have none other than Professor Dr. Sampath Kumari ma'am, who's the past Vice President of FOXI, who's the moderator for the panel. And we have our esteemed panelist, Dr. Rakhi Bajpai, who is who's the immediate past president of JOGS and also the zonal chairperson of IMA AMS Jabalpur division. And ma'am is also the ex-treasurer of IMA AMS and vice president of JOGS 2023 to 2025. Welcome, ma'am.
Thank you.
Dr. Komal Jain, who's the past president of Jabalpur Obstetric and Gynecological Society. Dr. Aditi Rathore, who's currently the West Zone Coordinator of Midlife Management Committee and also the Secretary of Ratlam Obstetric and Gynecological Society and a Senior Consultant at Ratlam. Dr. Priya Kannappan, who is the Executive Council Member of OXI, and she's also the South Zone Coordinator of Quiz Committee of FOXI. Next slide, please. Dr. Meena Mahalingam, who is the immediate past Secretary of Obstetric and Gynecological Society of Southern India. And ma'am is also Master Trainer of EMOC. Dr. Monisha, who is the who's a consultant at Obstetric and Gynecological Society at Chennai, and who's assistant professor currently there. Dr. Nazia Sheikh, who's currently a consultant at consultant assistant professor at Sri Mutkamar Medical College at Chennai. Yes.
So, Madhu, I will share my slide.
Priya, can you share the slides?
Sharing.
Yes.
So I hope my slides are visible, ma'am.
Next slide.
Yes, ma'am. So on behalf of Sampath Madam, we would request everyone to support Madam in the upcoming elections. We are going on elections for the FOXY with the post of president for the year 20, this year we are doing 26. It is the election is in August between 1 and 10. Kindly vote for Dr. Sambat Kumari Madam.
Thank you, Dr. Priya. So now we will start with Priya itself. Now the patient, we are having a lot of high risk cases. In the cases of hypertensive disorder in pregnancy, how are you going to classify the hypertension in pregnancy?
Yes, ma'am. So generally, we will keep it as hypertensive disorders and preeclampsias. Usually, when it occurs before 20 weeks, we call it as chronic hypertension. Sometimes we have to think in terms of white coat hypertension. So only one value, we don't diagnose that. At least 4 hours apart, if at least 2 values are there, then we give a diagnosis of hypertension. And and this can be either it can be essential hypertension, which means there is no other reason for that. And sometimes nowadays we are getting patients who are having already a diabetic with the CKD or SLE, which is the reason for hypertension. So that can be secondary hypertension. And per se with pregnancy, which occurs after 20 weeks, when it is only with only hypertension, no other end organ damage, we call it as gestational hypertension. When either there is proteinuria or any other systemic damage like end organ involvement, including liver function test is abnormal or a kidney involvement, or even when there's an FGR, we classify them as preeclampsia.
Yes, Priya. I think Dr. Monisha, how are you going to classify this gestational preeclampsia and eclampsia? Dr. Monisha?
Monisha?
Yes, Dr. Nasia can take up.
Yes, ma'am. Good evening, ma'am. Gestational hypertension is like a BP of more than systolic 140 and diastolic 90 mmHg after 20 weeks. That too, readings taken 4 hours apart. And the thing is, after delivery, postpartum, BP recordings will be normal if it is gestational hypertension. If it is chronic hypertension, even after 12 weeks, BP will be elevated. So that we have to treat as systemic hypertension. Preeclampsia, along with the 140/90 BP, other signs of multi-organ failure, anything related to RFT, LFT, blood coagulation disorder, or cerebral edema, that like blurring vision, photophobia, photopias, all this, or epigastric pain due to the liver hemorrhages, anything might be there. Any of the symptom might, we'll call it as preeclampsia. Also,
Yes.
along with that, placental pleasant factors like FGR, oligamenos, and abnormal Doppler indices also classifies preeclampsia.
So finally, when it is before 20 weeks, we call as chronic hypertension. That is hypertensive patient becoming pregnancy. So when it is during the pregnancy, after 20 weeks, that is after the placental invasion is, we consider as gestational hypertension. When it is associated with proteinuria, we consider as preeclampsia. Preeclampsia can be severe preeclampsia or non-severe. Severe will have the end organ damage symptoms. Non-severe will not have the end organ damage symptom. In severe, proteinuria may be present. If there is associated fits also, then we class as eclampsia. So, gestational hypertension, preeclampsia, eclampsia, and chronic hypertension. This is the way we are classifying. Now, Dr. Yadav sir is there. Sir, can you explain the pathophysiology of this preeclampsia? Do you think this all anyway? Do you have any risk factors, or any patient can go for PAH? Yadav sir, are you there? Dr. Aditi, you can take up.
Dr. Aditi ma'am? Dr. Raki ma'am is there, ma'am.
And Dr. Raki?
Hello, good evening, madam.
And Dr. Raki Bajpai. Yes.
Ji,
Can you
ji,
explain the
ma'am. Thank
pathophysiology?
you.
Next slide, Priya. Yes, Raki.
Hello, madam. Yes, madam. Madam, risk factor, are you asking? What are you asking,
No,
madam?
pathophysiology. What is the normal pathophysiology of preeclampsia? Yes, we can go with this. The maternal mortality. What is the incidence of maternal mortality with HDP?
Madam, with HDP, the maternal mortality is, it is the second largest cause of maternal mortality, HDP. It is 8 to 10% of all pregnant women are involved. And it is the second most commonest cause after the anemia and postpartum hemorrhage. And the
Yes, now the
preeclampsia.
maternal mortality, the two common causes, one is PPH and PAH. We do not know which patient will go for PAH and which patient will go for PPH. That is the reason always we focus on PPH. Last week we had the PPH class and now we have the master class with the PAH. Yes, Raki. Next slide.
Yes,
see, Dr. Raki, can you tell about this gestosis score? Are you following in Jabalpur?
Yes, madam, we are following it. And the risk involves the score of 1, 2, and 3. The risk factor when the woman born as small for the gestational age, it is 1, maternal anemia is 1, age older than 35 years is 1, younger than 19 years is 1, obesity, that is BMI of more than 30 is 1, nulli gravida is 1, short duration of paternity is 1, family history of preeclampsia is 1, cardiovascular disease is 1, PCO 1, and pregnancy interval of more than 5 years is 1, assisted reproductive procedures like IVF, XC is 1.
Yes.
And the maternal hypothyroidism is 1, chronic vascular diseases, dyslipidemia, and excessive weight gain during pregnancy, and MAP of more than 85 is 1. And
So
the
that is the
gestational
history elicitation. History is very, very important. With this, as
Yes,
you
ma'am.
told, 1, 2, 3, we are going to do. If it is more than 3, we can know that it is a prediction that this patient can go for preeclampsia. Now, there are many biochemical tests, but this is the FOXY gestosis score. FOXY ICOG gestosis score, the recommendations are there. With this, now in Tamil Nadu, we have this score in all the antenatal patients. We can do it at the first visit and at the 12 weeks. And we can have an idea that that patient can go for the preeclampsia. Thank you, Dr. Raki. Next slide, Priya.
Thank you so much.
So now, Monisha, are you there? Or
Yes, ma'am.
Aditi, you can take up this
Yes,
question.
ma'am. I am here, ma'am. Dr. Monisha. I'm
Yes,
here, ma'am.
Monisha. See, this
Yes,
is 24 weeks priming with a BP 150 by 100, but she is having no complications. So how are you going to manage this patient?
Ma'am, a
The
priming
gestation
gravida with
age is
24 weeks gestation, and her BP is more than 140/90 millimeter mercury. So I would want to start the antihypertensive medication. At least for the first time, I want to admit her and evaluate her lab parameters. I will start with the first line drug labetalol, which is 100 milligram BD dose. I would start, and the target BP I would like to achieve is 135/85 millimeter mercury, ma'am.
Yes, always the labetalol. Labetalol is the main drug for the during pregnancy. In this patient, since the age 24 weeks corresponds with the gestational age and no other complications, it is a case of gestational hypertension. You can go with the labetalol. So maximum of labetalol can be 2,200, but for practical purpose, we are going up to 600 to 800. Only BP is elevated means we are starting only with the labetalol. Previously, we used to think edema, proteinuria, and daily elevated BP. Now, edema is common. It can be physiological, and proteinuria is present for other cases also. So, we consider only the elevated BP. So, appropriate cuff is important. With the obese patient, you cannot have a pediatric cuff, appropriate cuff 1 centimeter above the cubital fossa, and the position, the patient monitoring should be in the sitting posture or in the left lateral posture. So BP monitoring is very, very important, which will be very useful. Dr. Nasia, what are all the other antihypertensives which can be used?
Other than
Next slide.
labetalol, yes, ma'am. Apart from labetalol, which is a alpha plus beta blocker, we can also use nifedipine, which is a calcium agonist. So it blocks the calcium receptors there. Other than that, we have methyl dopa also, which is a central sympathomimetic drug. And we can also use
Yeah, next slide.
hydralazine, ma'am. Hydralazine also can be used. This is oral drug,
Hydralazine,
ma'am.
is it available here? Nasia, hydralazine is available in India?
No, ma'am. It's like not regularly there, ma'am. Because it's
So
IV drug,
regularly we
ma'am.
use labetalol and nifedipine. Hydralazine and hydrochlorothiazide, most of the time we are not using. Sometimes the nitroglycerin patch, with the help of the anesthetist, it can be used. If the BP is very heavy, 200 by 160, in that cases, we can go with IV labetalol. As we told, these are all the drugs which can be used. Okay, next slide. Dr. Aditi, can you take up this question? Gravida 2 P1L1 with 32 weeks gestational age. Patient was on antihypertensive since 4 weeks. And now the patient complains of headache and blurring of vision. So how will you proceed with this patient? Per abdomen, it corresponds to the gestational age. Dr. Aditi, are you there?
Yes, ma'am. Yeah, ma'am. Good evening, ma'am.
Is also present.
Good evening, ma'am. Ma'am, can you hear me?
Yes, Aditi.
Yeah. Good evening, ma'am. Ma'am, she's a case of gestational hypertension. She has been on antihypertensive since 4 weeks, and now there are these features which are pertinent to impending eclampsia. She's having headache and blurring of vision. So these are the danger signs. So we have to first and foremost admit this patient because she's a case of preeclampsia, and we have to manage her blood pressure. So she has to be taken into HDU setup, and her preeclampsia has to be managed. She has to be given anti-eclamptic drug, which is magnesium sulfate. We have to administer magnesium sulfate by whatever regime you just is better. And then after stabilizing the patient, and obviously the entire workup has to be done. All her investigations regarding her liver and kidney profile and coagulation profile has to be done. And then after prognosticating the case and counseling the relatives and discussing, and also we have to give her steroids also because she's 32 weeks of gestational age. So steroids have to be given, and according to the maternal status and stabilization, we have to terminate the case. We can do that. Is how in a nutshell that is what we should do.
Yes, Dr. Aditi. Dr. Who is the other panelist? Dr. Muditi Jain is there, no? She is not there. So, Dr. Priya, Aditi was telling that she want to follow the Zuspan regimen. How are you going to manage in your Mehta hospital setup?
Madam, we use only Zuspans, madam. So we are not the fans of Pritchard regimen. So, because Zuspans is easy to monitor, easy to do that. Because we have the drip rate, we just put it across. We have, we just preload the syringe. We just put it and we set it at the rate of 1 gram. That is 2 ml per hour. It is easy for us because we don't dilute in that 500 ml of NS. So there's no fear of overloading. So we directly load around, if you're planning for 24 hours, we load exactly 24 ampules, which is almost 48 ml. So 50 ml, we set it at the rate of 2 ml per hour. So that will be our maintenance. And for our loading dose, it is 4 grams. So we dilute it with 12 ml of normal saline. We make it in a dilution of 20 ml. So that we give it as a loading dose over 10 minutes. So once we give a loading dose of 4 grams, we dilute it with 12 ml of NS. We give it over a period of 10 minutes. And 10 to 15 minutes, and then we start directly with the
infusion pump.
Yes, with an infusion pump, yes. And most in our hospital, we have a protocol of catheterizing the patient to monitor the urine output, and we meticulously monitor the deep tendon reflexes and the respiratory rate. We chart it and we keep the patient in HTU during the period of MaxSelf course, madam.
Yes, sir. Any one of the panelists who would like to tell about the Pritchard regimen? See, in the primary health center.
Pritchard
Pritchard
regimen is
regimen
usually intramuscular what we have given, ma'am. But loading dose again, it is like 14 grams. In that, 4 grams IV is given. Like 4 ampules diluted to again total 20 cc, and then we'll give over 10 you give over 10 minutes, followed by 10 gram loading dose. In that, 5 gram IM in each buttock. After that, every 4 hours we give 5 grams maintenance dose in
Next slide, Priya.
alternate butts, ma'am.
Yes,
And the
because
thing
of the
is,
primary health centers and the other
Yes,
places
ma'am. Yes, ma'am.
where there is no one-to-one care, in that cases, you can go with the Pritchard regimen. Main disadvantage is that ampule 10 ml has to be given on the both
yes, ma'am.
gluteal region, and it has to be continued every 4 hours.
Mm.
So normally, for the sake of the delegates, the Pritchard regimen is 4 gram 20% IV. That is the reason they were telling. So 4 ampule, take 8 ml in 20 ml syringe and dissolve with 12 ml and give IV for 10 minutes. And then 5 gram in the each buttocks. 5 gram means it is 10 ml. That is the reason now the Priya was talking about the Zuspan regimen. That is 1 gram per hour. That is the reason. But if a one-to-one care is not present, and only the nowadays even the Pritchard regimen can be done even by the paramedicals. That's the reason we are talking about this. How long we are going to continue is for 24 hours.
24 hours.
Every 4
hours.
hours, 5 gram IM has to be given. So Aditi, with the, in between these 4 hours, what are all the things you want to monitor?
Ma'am, we will have to monitor the patient's respiratory rate. It should be like more than 15 or 16 per minute. Then we have to be very cautious about the urinary output. The initial loading dose can be given, but later on urinary output, which will be 30 ml per hour or 100 ml in 4 hours. Then you have to see for the patellar reflexes. If we in bike in if there is something we can obviously we can exclude or skip the dose, and we have to, if there is toxicity, then we should have calcium gluconate ready with us.
Yes.
So I think it is like 10 ml of 10% solution is to be administered.
That is 1 gram. Okay. Next slide, Priya. So this is the way we are going to give the Pritchard regimen. Zuspan regimen, as Priya told, whatever is convenient. Zuspan, there is no harm for the IM injection. But in a small resource, low resource setting, it is better to go with the Pritchard regimen. Next slide. Yes, Priya. So these are all the imminent symptoms. So always for a PAH patient, we should ask if the BP is increased and the patient is gestational hypertension, means we have to ask whether headache, that is not relieved by taking rest, blurring of vision, upper epigastric pain, it can be the HELP, and urinary output, it can go for glomeruloepitheliosis. These leading questions we should ask the patient to avoid the complications. Our aim is no mother should die because of the pregnancy. That too for the preeclampsia. So if these symptoms are present, we can know that she is going for preeclampsia, and if we don't identify this, then patient can go for eclampsia. Next slide, Priya. So this is the pathophysiology, as already we told, the second invasion where there can be the vasoconstriction. So the placenta is the culprit. Once the placenta is delivered, the BP can become normal. Next slide. So proteinuria, this 24 hours urine, most of the time now we don't do. We go only with the dipstick. Any one of you are going the 24 hours urine?
No.
Nowadays, it is not advisable. Next slide. So these are all the early onset and the late onset preeclampsia, that is before 34 weeks and after 34 weeks. Then this PREP collaborations, MACPI trial, these are all needed for the post-graduation, because the MACPI trial, how many patients are doing. Now we go only with the original dose, no low dose and the no prophylactic dose of magnesium sulfate. Next slide. So this is the PAH tray that it has to be kept everywhere. Labor ward, antenatal ward, theatre and casualty. With the 16 ampule glove, magnesium sulfate, labetalol, and 2 ml syringe, 20 ml syringe, IV fluids, calcium gluconate, knee hammer. It should be kept ready. After the patient is throwing fits, you cannot go and search for magnesium sulfate. Next slide. So Dr. Monisha, can you take up this question? This is the patient on antihypertension, which she had fit twice in the house in spite of the antihypertension. She comes to the OP and her BP is 200 by 110. Now she is throwing fits in the in front of you in the casualty. How are you going to monitor? These are all the common cases which we see.
Yes,
Yes,
ma'am.
Monisha.
For this patient, first I would like to stabilize the patient. And then
Next slide.
airway breathing circulation should be ensured. First of all, I will call for help. I will shout for help
Yes.
and then start the resuscitation. Airway should be maintained and should check for the breathing, and IV access should be made, and max self loading dose should be given. And the BP is 200 by 110, so I would like to reduce the blood pressure with the IV labetalol. But in usage, we have experienced labetalol infusion to be better over the labetalol bolus doses. So I would start with 20 gram, and then another bolus dose can be given like 40 gram, 40 milligram, and then 80.
So another
The
40, when will you give, Monisha? That you have to explain. See, 20 you are giving. After
yes, ma'am.
10 minutes, you see the
After 10
BP.
minutes, I will check the BP, ma'am.
Yes.
If it is persistently high, I will give 40 milligram, and then the repeat dose 80 milligram I will give. The maximum dose that can be given is 300 milligram, ma'am. And
No, most
other
of the time
drugs
with 160 milligram, the BP will get reduced.
get
Okay. Then
reduced, ma'am. And the IV infusion dose is 1 to 2 milligram per minute, ma'am. Or else the other drug, oral nifedipine, can be used, but with a patient throwing seizures, we are not advisable to give the oral drug. Maxel, after stabilizing the patient, I will take up for the termination or depending on the Bishop score, ma'am. If it
so if the Bishop
normal
score is
delivery,
3, what
otherwise
will you
better to
do?
go for for cesarean section, ma'am.
So that is the main thing. Bishop score, if it is 3, and don't take for induction like that. Suppose once to stabilize the patient, or you see the pervaginal examination, and if the dilatation is 6 centimeter and baby is below that spine, means then you can go for the normal delivery. For 6 centimeter, it is not possible to go to the theatre. The scalp syndrome, eclampsia, everything, don't hesitate to do the LSCS. So as Monisha told, call for help, always ABCD, airway, breathing, and IV circular. And whenever you start the IV, take blood sampling for LFT, RFT, coagulation profile. For all hypertensive patients, you should have a basic value. Rather than the routine investigations, you should have a LFT, RFT, coagulation profile, echocardiogram, fundus examination. This basic should be there. Then only in future, like this, if the patient has the complications, we can see whether there is the derangement with the blood investigations. Then after correcting, stabilizing the patient, you are going to deliver the baby. Next slide. Thank you, Monisha. Priya,
Yes,
next slide. So this is the case of a patient with labetalol and nifedipine comes to the OP with the complaints of the abdominal pain. She is 32 weeks. Abdomen is tense and tender. What do you think, Dr. Priya? Or any one of the panel, Dr. Aditi, you can take up, I think. Muditi Jain is not there, I think, and Yadav sir is not there.
Ma'am,
Yes, Dr.
Dr. Raki is there, ma'am.
And Dr. Raki is there. So the Aditi can take up this case and the Raki can take up the next case. Aditi, what is your
ma'am, she's a
diagnosis?
34. Ma'am, she's a case of 32 weeks primary. She's on antihypertensive, labetalol, and nifedipine, and she comes with severe abdominal pain, and her abdominal is tense and tender. So this points towards abruption, which is a very common complication. Yeah. So, ma'am.
So since the abruption, depending on the abruption, if the baby, suppose if this is a case of abruption with IUD, how are you going to proceed, Aditi?
Ma'am, actually, this case just reminds me of a case I just had recently, basically. So I would obviously go for investigations and immediately, as you said, basic investigations, complete blood count, her INR, coagulation profile, platelets have to be seen, then liver and kidney management. And obviously, I might go for a quick scan also and do a LSCS with arrangement of blood and fresh frozen plasma, which should be done. But I'm working at a very basic center, and then after proper consent, and we'll deliver the baby and manage the mother accordingly.
Yes, that's the way we have to treat the abruption. Always keep ready the blood components. Whatever is needed, you can have it. Next slide, Priya. So these are all the other complications of the HDP, abruption, visual disturbance, intracranial hemorrhage, pulmonary edema, oliguria. For the baby, as usual, IUGR, preterm, hypoxic, low birth weight, and perinatal mortality. So always we have to explain to the patient, these are all the complications that can happen to the baby, that can happen to the mother. So you should be prepared. If at all needed, if there is no facility in your hospital, we will refer the cases to the other hospital. The counseling part is very, very important. And always don't risk, take risk here. If there is no facility in your hospital, give the loading dose and make all the documentation and refer the patient to the place where the facilities are available. Mainly the HDU, anesthetic facility and the reviving facility, everything should be there. Next, we'll go to the next slide. Priya, next slide. So this is the 34 weeks, Raki, you can take up this question. 34 weeks of that patient is having the upper epigastric pain. She was on labetalol and now per abdomen it is normal. Suppose that pregnant patients comes to you with upper epigastric pain means don't tell that you take antacid, you will become normal. Always think of, what will you think of? Dr. Raki? Dr. Monisha?
Ma'am, it can be a severe feature, subcapsular hematoma or hepatomegaly can be present in preeclampsia patients. So we should check her BP and do the investigations look for LFT and RFT derangement, platelet count, uric acid, and the proteinuria should be assessed, ma'am. Since she is only 20 weeks, we have to prolong
No,
for
she is
preeclampsia.
34 weeks.
Oh, sorry, ma'am.
And
Patient
what
is
34
34
weeks.
weeks. Patient is on
Yes, ma'am.
labetalol from 20 weeks.
From 20 weeks. Yes, ma'am. I would start her on steroids, ma'am. I would give at least 1 dose steroid coverage, and termination for preeclampsia with severe features can be done from 34 to 37 weeks.
Now, for suppose the platelet is 40,000. Will you wait for the steroid effect?
No, ma'am. We have to do platelet transfusion just before entering the OT and then take her up for section, ma'am. Preferably single
Yes.
donor platelets, ma'am.
Yes. Next slide, Priya. So always if it is the HELP or eclampsia or severe preeclampsia, you can, if the patient is stable, you can wait for the steroid effect. Otherwise, don't hesitate to terminate the baby as early as possible. This patient, control the BP, give the magnesium sulfate, depending on the blood products, give the blood components and then terminate according to whether the patient is stable and everything is good means, as she told you, we can wait for steroid effect. If the platelet is less and the coagulation is going on and liver enzymes is highly elevated means we have to terminate. Once we are terminated, we are on the safe side. Okay. Thank you, Dr. Monisha. So the delivery, how are you going to deliver this? Priya will tell. Priya will tell when, if it is 28 weeks, when, what will you do? 28 to 33 weeks, what will you do? If it is more than 37 weeks, patient develops preeclampsia. What will you do? Yes, Priya.
I mean, it depends upon the severity, madam. If you just have just a high BP value alone, or if just a BP and the proteinuria,
Consider it
no
as
other
high BP
symptom. Yes.
with the symptoms.
So, with imminent symptoms, then I will do the blood workup and then we will see whether the BP is under control. If the BP is under control, then if it is 28 weeker, I will try to at least prolong it to 34 weeks, but not in a case of HELP or eclampsia. If it is just symptoms, but it disappeared, the symptoms have disappeared, then we can wait. Otherwise, we will decide then and there. Whenever we decide on a preterm preeclampsia delivery, cesarean is much better for the patient as well as for the baby. So 28 weeker we cannot induce because that baby will not be able to withhold the stress of labor. So less than 34 weeks, we will not try to induce them. More than 34 weeks, if depending on the Bishop score, if you are looking at a favorable delivery within a few hours, we can even induce and deliver. But in experience, what we see is most of our preeclampsia patients, they respond well. Like their cervix are like, they dilate early. It's not like, it's going to take too much of time. Most of them, they respond as well.
Dr. Rekha, do you want to tell anything? Dr. Rekha Singhal?
No, ma'am.
Okay.
Okay.
Yes, Priya, continue.
In that
Early,
patient,
yes, ma'am.
Yes, Priya.
If it
Suppose
is
this
very
patient is 24 to 28 weeks. How will you counsel the attender?
So if it is 24 and 28 weeks, madam, first thing, we will see what is the maternal age and what is their perspective on this child. If the child is viable, like, in our setup, we our 24-weekers survive. And if the patient is able to pay the NICU cost, then we will even decide on cesarean section and we deliver the, like the viable baby there, 24-weeker. If it is just married 6 months, like a very young female. So we are looking at a better future for her. Even if this
Yes.
pregnancy we are terminating, she will get another pregnancy. In those cases, we will counsel for termination, like, we will try to expel this baby. And in the next pregnancy, we put her on aspirin and we will assess the risk and we will try to get a better pregnancy rather than going on for this one.
Yes, Priya, it's well done. So less than 24 weeks, no other way we are going to terminate. 24 to 32 weeks, as she told, depending on the NICU center and the importance of the baby, we have to counsel. If it is more than 34 weeks, whatever may be the place, it is better we will terminate and the baby can be revived. Thank you, Priya. Next slide. So the mode of delivery already we have discussed, depending on the position. If the Bishop score is good and patient is stable, you can go for vaginal delivery. If the Bishop score is not good and patient is unstable and severe conditions like HELP, pre-eclampsia means LSES only. Next slide. Fluid restriction is important. So this is the last case. I think Dr. Nazia will take up this question. Primipara delivered 2 weeks back. Patient, most of the time we give the patient on antihypertensive, we discharge only after 5 days. Sometimes the patient with the need, they will go immediately within 48 hours if everything is okay. This patient has left. But in the house, she has developed a headache, that is postnatal headache. BP is 160 by 100. Now she comes to the Muthukumaran Medical College. Dr. Nazia, what will you do?
Yes, ma'am. This patient has already delivered, looking like postpartum hypertension, ma'am. These patients generally antenatally they do well, they don't have any signs or symptoms, but after delivery, preferably like 48 hours after delivery, there might be elevated BP and associated like headache, blurring will be there. We should not ignore those symptoms, ma'am. We should evaluate again. We have to send PAH profile, and labetalol again is the first drug of choice in this case.
So what will be the finding with MRI? The labetalol and magnesium sulfate you are going to give. Suppose before delivery, if you don't give magnesium sulfate, now you are going to give the magnesium sulfate. Suppose the MRI report is what is PRESS?
Posterior reversible encephalopathy syndrome, ma'am. It is common usually after post-delivery it is presented. There will be cerebral edema in the occipital lobe. So again, we'll give mexsulfate and like mannitol to reduce the cerebral edema. And then we have to monitor patient. We have to see that she doesn't go in eclampsia, ma'am.
Okay. Dr.
And
Priya, do you
actually,
agree that
the progress will be better for this patient.
Priya, do you agree for the mannitol?
Usually we don't give, madam, for press. The only treatment for press here is the stable control of BP. What usually happens is that we, the sisters, they try to skip the antihypertensive when the BP is 110 by 70 or 120/70. They say that, okay, BP is normal, they skip. Then what happens, the second dose, it goes to 160 by 110. Then immediately we give a nifedipine, suddenly it falls to 90. So when we have these peaks and troughs, this up and down movement of BP, that is the main reason for press to happen. So if we maintain a stable BP level, press doesn't come. Second thing is it resolves on its own, provided we make sure that the BP is under control. So the only thing we do is antihypertensive, and if at all seizure prophylaxis, some of us we give. We just put a tablet levetiracetam because it is a little safer drug, not much, and most of the neurologists, they just advise to be taken it. But actually no role, only hypertensive control has a role here, ma'am.
So observation, that's all. It will resolve by itself by 6 weeks. Most of the time we don't go with the mannitol nausea. So this is for observation. Okay. So these are all prediction and prevention. You had the wonderful talk by our Dr. Madhuri. Next slide. The prediction, nothing can predict. Now we go with the SFLT, PAGF ratio, whether it is less than 30 or more than 80. If it is more than 80 means we are going to terminate. 30 means every 4 weeks we have to do the SFLT. It is very, very costly. Then similarly, the PAP, everything depending on that, we are going to do the predictions as Madhuri Madam was explaining. Next slide. The regular exercise, lifestyle, this prognosis study, Pelican study, And these are all for continuing for 2 weeks or 1 week. This is the way that this is mainly for the PGs. They may ask what is prognosis study, what is Pelican study, what is MACPI trial, what is PIES model, what is Gestosis score. These are all for the completions. Next slide. So the conclusion is mainly monitoring the BP is important. Follow up the patient. If the patient is not coming, give her a call and ask the patient to come and control the hypertension to avoid the complications and identify the complications at the earliest stage and refer it as early as possible. And really, I thank the wonderful panelists, Dr. Nasia, Monisha, Dr. Priya, Dr. Aditi, and Muditi Jain, and the sir. I think he has not that Raki, everyone. So thank you all. And once again, my humble request to vote for me. I am contesting for FOXI president. So my aim is mainly with the adolescents and the high risk pregnancy and the menopause screening. So please vote for me and make your friends also to vote for me. That your election time is August 1 to 10. Thank you all.
Thank you,
Thank you,
ma'am.
ma'am.
Thank you, ma'am. It was excellent webinar.
Thank you. Thank you, Dr.
Thank
Archana.
you.
Yes,
Ma'am, best
stop
wishes.
sharing.
Best
Archana?
wishes for the upcoming Foxy President election. Your
Yes,
patience and
Dr.
commitment
Archana.
make you a great leader, ma'am. Thank
With
you.
all your supports, I should become. So
Sure, ma'am. Sure,
I have a
sure.
lot of plans in my mind. We will do it.
Sure, ma'am.
Okay,
Sure.
thank you all. Thank you,
Thank you.
all the Madhya Pradesh Society President and Secretary. In spite of your busy time, you have
Thank you,
joined.
Dr. Sampath. May all your ambitions be fulfilled.
Thank you, Dr. Madhuri. Thank you. Now we will go to the formal vote of thanks. Dr. Priya, can you tell the vote of thanks?
Yes, ma'am. So, on behalf of the TNFOG, I would really like to thank each and every one of you who have joined the webinar. I would thank all the presidents and secretaries of the Madhya Pradesh societies and the Madhya Pradesh Obs and Gyne Society president as well. Thank you for joining. I would like to thank Dr. Madhuri madam for the excellent lecture and Sambat madam for the excellent panel, along with Dr. Rakisan, Dr. Aditi madam for the being our panelist, and Dr. Monisha, Dr. Nazia, and I think thank you everyone, and thank you Dr. Jyoti madam for accepting to be the chief guest. So thank you one and all, and kindly
Sharing. Chief guest Anjali madam, she didn't come.
Oh, thank you, Jyoti ma'am, for sharing the session. And I would request one and all to kindly support and vote for Dr. Sambat Kumari madam in the upcoming Foxy election, August 1 to 10. Thank you once and all. Thank you.
Thank you. Thank you, Dr. Priya. Good night to everyone.
Good night. Good
And
night,
thank you,
ma'am.
Sahati,
Good night.
for the wonderful platform. And thank you, Madhu.
Yes. Thank you, Priya. Good night. Thank you, Madhuri, Dr. Archana,
Thank
Raki.
you, ma'am. Good night, ma'am.
Good night. Good night.
क्या हुआ? अभी तो आए सर बाथरूम में अभी क्या हो गया? तो मेरा फेस वॉश ले लें। तो फेस होता है क्या? क्या? लगा के नहीं